Good morning, everyone, and welcome to today's webinar. On behalf of Boston IVF, we're pleased to host today's webinar, Age and Fertility, presented by Dr. George Kovalevsky of the Delaware Institute for Reproductive Medicine, part of the EVRMA North America Network. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around midsummer. Now, without further ado, I would like to introduce today's speaker. Dr. George Kovalevsky is a board-certified reproductive endocrinologist at Delaware Institute for Reproductive Medicine. Dr. Kovalevsky completed his undergraduate studies at Brown University in Rhode Island. He then received his medical degree from the University of Rochester School of Medicine in New York. Next, he trained in obstetrics and gynecology at the Ohio State University in Columbus. Finally, he completed a fellowship in reproductive endocrinology and infertility at the University of Pennsylvania in Philadelphia. Here, he also received training in clinical epidemiology and biostatistics. Dr. Kovalevsky is part of the EVRMA North America Network, and he practices at the Delaware Institute for Reproductive Medicine. He currently practices in the Newark and Milford, Delaware locations. He specializes in all areas of reproductive medicine, including assisted reproductive technologies and operative hysteroscopies. We encourage you to submit questions to Dr. Kovalevsky using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them at the Q&A session at the end of today's presentation. All right, we're going to get started. I'm going to pass it over to you, Dr. Kovalevsky.
Thank you very much, and thank you everyone for joining. Today our topic is age and reproduction. Age is such an important factor when we talk about fertility. It is the single most important predictor for success when we talk about fertility treatments, and it is such an integral part of everything in reproduction as we do our counseling and management before pregnancy and during and after. And it is also the one area where we have very little control. We cannot reverse aging. We cannot stop aging. So that is why it's so important for us to understand how it impacts reproduction, and that's what we're going to be talking about today. So our objectives, first, to review the current fertility trends in the United States, understand the impact of age on reproduction, and then talk about what options do we have in our toolbox to deal with the aging, particularly for women. So first, let's look at some of the epidemiology. The fertility in the United States, fertility rate in the United States has been declining in the recent years. It is at its lowest in our recorded history. There was a drop in fertility in the later 1970s, and that was due to multiple factors, including increased contraception availability for women entering the workplace in larger numbers, cultural changes. But after that, fertility rates rose. And then since the early 2000s, we've been on the decline. That the current fertility rate is only 1.6. So that is the number of births over a woman's lifetime. That is obviously not nearly enough to replace the population of this country. So we've calculated that we need 2.1 fertility rate for us to maintain population. Of course, the immigration helps replenish the population, but without that, we are going to start losing, especially younger people in the population will get older. The other aspect of the declining fertility rate is that women are delaying childbearing till much later in life. And that is a very important factor for fertility. We see that this phenomenon is affecting all communities in the United States. In general, in the large metropolitan areas and the big cities, we see that women delay fertility till much later in life. And currently that's almost 28 years of age before first birth. Even though in the rural communities, the age is significantly lower at 24 and a half, we still see the same pattern that everywhere in the country, whether it's in the cities or in the rural areas, women are waiting till later in life to start having pregnancies and start having children. And then if we look at childbearing by age group, we see that we've accomplished a great reduction in teenage pregnancy rates. So those are way down, and obviously we think that's a good thing. But for the middle reproductive years, there is still a big decline as well. And then we see that as women enter the late 30s and 40s, we see the biggest actual rise in fertility. So the overall fertility rate is going down. Women are waiting till later in life to have children. And that is an important aspect of why it's harder to become pregnant and why pregnancies are more risky. So just a very quick question to challenge you. What is the approximate monthly pregnancy rate, also known as fecundability, for a normal couple on average? And so most people, if you ask in the general community, will think it's quite high, especially given the number of unintended births in younger women. But it is only about 25%. So overall human reproduction is very inefficient. And then we have a significant drop after that with miscarriage rates. So the fecundity is only at about 20% per month. Fertility is very much impacted by age, as I started out saying at the onset. The fertility for women declines with age. And so this is a classic diagram that shows data from long ago, 1600s, 1700s, 1800s, and it looked at communities that practiced no contraception, no abstinence, nothing to avoid pregnancies. And for them, we see that the natural fertility rate in married couples who were not doing anything to prevent pregnancy drops significantly with age. And so we see that this drop becomes particularly noticeable in the mid-30s and then plummets after 40. Why is this? Why is the fertility rate decline with women's age? Well, there are a number of explanations. Number one is the concept of decreasing ovarian reserve, fewer eggs left. Second, the increasing rate of aneuploidy in the eggs. We don't know for sure why the eggs released earlier in life have a higher rate of being normal, whereas eggs released later in life have a much higher aneuploidy rate. But that is simply a fact. There are other reasons besides aneuploidy. There's increasing cumulative incidence of pathology with age. So as a woman gets older, there's higher chance that she will develop problems like fibroids, polyps, endometriosis. There could be other diseases that cause infertility as a comorbidity. So many things can go wrong that will decrease the overall potential for fertility. And then beyond the aneuploidy within the eggs, the overall quality of the eggs goes down as well. Mainly, we focus on the mitochondrial factories within the eggs that may start to not function normally, causing the eggs to be less competent towards fertilization and normal division and development. The concept of age for men and reproduction is not nearly as important. Men continue to make sperm throughout life and can have children later on in life. Yes, there are definitely changes in the quality and quantity of sperm with men's age, but it's not nearly as important of a factor towards successful reproduction. There are studies that have shown some worsening outcomes, and semen analysis done throughout men's age reveals that there are drop-offs in all aspects of the semen analysis, the quantity, the motility, the morphology. So definitely there are some things that get worse with age. The main thing we focus on is the increase in DNA fragmentation in the sperm. This has been associated with lower fertility and particularly increased miscarriage rates, as well as potential increased risk of fetal problems such as autism and schizophrenia. DNA fragmentation in sperm can be evaluated, and there's a number of assays available commercially. And so one of them in this chart shows that if the DNA fragmentation increases above about 25%, we see significantly worse outcomes, particularly with increased miscarriage. We know that we can do something to help. Lifestyle can improve the DNA fragmentation. We can sort the sperm and select the sperm that have less DNA fragmentation, although the efficacy of the sorting technology is still not completely proven. We can select the sperm individually for intracytoplasmic sperm injection, ICSI, when we do IVF. And ultimately, if none of that is successful, we can send men to the urologist to have sperm aspirated from the testes, because we think most of the DNA fragmentation occurs after the sperm is produced and as it undergoes transport through the epididymis and the collection tract. So taking testicular sperm is likely to have much less DNA fragmentation, but that is a measure of last resort usually, because it's an invasive procedure that is more costly. So turning back to the women's side of things, let's focus a little bit more on the concept of ovarian reserve. Unlike men who continue to make the sperm throughout life, with women, women are born with all the eggs they're ever going to have. So a fetus at its maximum starts out with something like 6 million oocytes. By the time birth occurs, most of those eggs are lost. They undergo rapid atresia, so only about 1 million sperm or 1 million eggs are present at birth. And then before a woman even starts to menstruate, as she goes through puberty, another 300, 400,000 eggs are lost. Then during the reproductive years, eggs continue to be utilized from storage until they're all gone. And of course, that is menopause. And so we see on this chart with the y-axis being in a logarithmic axis, that the decline is particularly precipitous after the mid-30s. So that's when really the fertility starts to go down faster and faster as the number of eggs decrease dramatically. We can estimate ovarian reserve. We have several tests that give us an idea of the quantity, the number of eggs left in storage within the ovaries. Traditionally, the oldest test that we still utilize is the FSH level on cycle day 3. By cycle day 3, estrogen levels are supposed to be rising, inhibin levels rising, so the FSH level normally is suppressed. If it is not adequately suppressed, that means that there's not enough follicular development to cause that suppression, and so that's a sign of diminished ovarian reserve. So we look for FSH levels on day 3 of a menstrual cycle to be low, preferably less than 12. We always have to check the estradiol level to make sure that the FSH is not falsely suppressed. So sometimes women with diminished ovarian reserve have a follicle or two that develop prematurely, and they produce higher estradiol levels, which then causes more suppression. And therefore, if the estrogen level is high, then we cannot trust a low FSH level, because that is likely a falsely low FSH. The second assessment of ovarian reserve is the antral follicle count. An ultrasound done in the early days of the menstrual cycle can count the number of early follicular activity antral follicles that are developing. And we're looking for follicles less than 10 millimeters in size. And we want to see a bunch of them, because if we see in this one snapshot on this day a good number of eggs, follicles in development, that suggests that there is a good number of eggs, follicles in storage. So we're looking for double digits, 10, a dozen or more, to be reassured. On the other hand, if the number is low, less than 5, that is usually a sign of low ovarian reserve. And then lastly, the test that we utilize and trust the most in this respect is the anti-Mullerian hormone, AMH. AMH is particularly useful because it is less impacted by the menstrual cycle and the hormonal environment. So we can check AMH levels even in women using oral contraceptive pills and still get a pretty reasonable understanding of the ovarian reserve. The AMH is produced by the secondary primary follicles within the ovaries, and we want to see a higher number here as opposed to the FSH, where we want a lower number. So in general, a number less than 1 is a bad sign for ovarian reserve, and a number above 1.5 is good. I want to highlight the concept of quantity versus quality of the eggs. These tests tell us about the quantity, how many eggs are left in storage, but they don't tell us about quality. Quality is best predicted by age, because age is the best predictor of aneuploidy. These tests are far from perfect. They're not precise. They can change substantially day to day, week to week, month to month. And it doesn't tell us necessarily about a woman's fertility or the rate at which fertility will decline. So if we use this as a screening test and simply check an AMH level for a woman in her reproductive years, if it's low, it does not tell us that she's going to have any infertility or difficulty becoming pregnant. Women with low AMH levels who have not tried to conceive and did not have infertility, this test does not predict that she will have problems if she attempts pregnancy at that point. Nor does it tell us the age of menopause or the rate of decline. It is particularly helpful, though, in predicting response to ovarian stimulation. So if a woman has low ovarian reserve on this test and is planning to do, for example, in vitro fertilization, we know that we should use a stronger protocol or adapt the protocol to address that. And we do not expect that there are going to be a lot of eggs that we'll be able to retrieve. So that will lower chances of success with the fertility treatment. However, again, separating quality versus quantity, a woman at 31 years of age with diminished ovarian reserve undergoing IVF may not yield a high number of eggs, but the chances those eggs will be normal, fertilize, and make good embryos that have a good chance of success will still be good. So the two concepts are important to separate. Once we see a diminished ovarian reserve, there's little that we can do about it. We can't restore it. We can't put eggs back into storage. We can't turn on the factory and make new eggs. What we have is what we have. That's what we have to work with. There are many things that can hurt the ovarian reserve. So when we see poor results on these tests, we often don't know why the ovarian reserve is low, but there are a number of things that we know can harm the egg quantity. In particular, we're well familiar with radiation and chemotherapy. We know that any surgery on the ovaries, aggressive cystectomies, for example, can hurt the eggs stored in the ovaries. Endometriosis, particularly endometriosis that invades the ovaries. And cigarette smoking has been clearly shown to diminish ovarian reserve and lower the age of menopause. Conversely, we know that ovarian stimulation, such as what we use for in vitro fertilization, does not further deplete the eggs. The concept here is that when the follicles are resting within the ovaries, they are stored as primordial follicles, and then something triggers them to start development. Not entirely clear, although we have a number of mechanisms that have been proposed. And they seem to enter this development process in waves, and a group of eggs follicles starts to develop without any control by the hormones that we think of, the gonadotropins or others that we're aware of. And so these follicles grow for a couple months without any hormonal influence until they become sensitive to the hormonal milieu around them in the ovary. If on that day that they become sensitive, the hormone environment is just right, that group of follicles will continue to grow. That'll be the cohort for that cycle. And of those, usually one will win out, become the dominant follicle that will ovulate that month. All the other follicles will die off. Now, on all the other days that a wave of follicles comes up from storage and is sensitive to the hormones, if on that day the hormones aren't right, all of those will die off and undergo atresia. So a woman's constantly going through the egg reserve every day of her reproductive years. When we do ovarian stimulation, we're not going into storage to get eggs. We have no way of accomplishing that. All we're doing is rescuing these follicles that would have otherwise undergone atresia without our intervention. So we're doing nothing to harm the reserve itself. And you can see with this concept that there's nothing we can do that's going to increase the recruitment of the eggs, follicles from storage, nor is there anything we can do to halt that recruitment. So birth control pills, pregnancy, Lupron, none of these things impact the recruitment of follicles from storage. So let's talk about the aneuploidy concept. We've already discussed that as a woman gets older, the chances of the egg being aneuploid increases. Therefore, the chances of an embryo being aneuploid also increases with age. And this increase is the direct opposite of what we saw with fertility. So again, this highlights the fact that aneuploidy is the #1 cause of the declining fertility with age. If an aneuploid embryo is the one that's present, if we try to implant it in the uterus, or if it happens in a natural cycle, most of the time aneuploid embryos do not implant and there'll be no pregnancy. If an implantation does occur, the vast majority of those embryos cannot survive, not compatible with life, and a pregnancy loss will ensue. And then only a small fraction of aneuploid embryos can actually proceed towards delivery and a live birth. And we know those are Down syndrome, trisomy 21, 13, 18, and Turner syndrome. Majority of pregnancy losses also due to aneuploidy. And hence, we see the same phenomenon that after, especially the mid-30s, the pregnancy loss rate increases faster and faster. So at around age 41, about a third of pregnancies will end in miscarriage. And after 43, we're looking at close to 50% or higher. So miscarriage rates also correlate with aneuploidy quite clearly. And then the trisomies that we've already mentioned, the aneuploid embryos that do make it to delivery, we see that that incidence increases with age as well, so that by the age of 41, the chances of having a child with a trisomy is about 2%, and half of those are trisomy 21, Down syndrome. And of course, we know that we have testing in the first trimester that allows us to detect most of these early. And then later on in the second trimester, we have other tests as well. Beyond having a successful implantation and making it through the first trimester, there are risks for older women later in pregnancy as well. And so data on this is not as abundant, but this is just one example of a systematic review of several studies that looked at these risks and looking at just several conditions. So gestational hypertension, we see that two cohorts were compared here, ages 20 to 34 to women 35 to 40, and we see there's a slight increase overall in the risk of gestational hypertension. When we go to look at women who are older, above 40, compared to women 35 to 40, we see a more prominent increased relative risk. And we see similar pictures for risk of preterm delivery, as well as perinatal mortality. So these conditions and others, the risks significantly increase with age. There are other additional risk factors that impact these outcomes, including the woman's BMI, high blood pressure, and cardiovascular disease. So with what we've learned, our main recommendation, the American Society of Reproductive Medicine has been for years campaigning to educate women that the best idea is to complete childbearing before the age of 35, if at all possible. But of course, we know that that is not possible for many, and either this information is not reaching women or it's falling on deaf ears, because the slides I showed you at the beginning show that clearly women are waiting later and later in life to attempt childbearing. So mostly so far I've presented you bad news. It's doom and gloom. But I do want to share with you that there are some things that we can do. There is a ray of sunshine that hopefully can break through some of these clouds. So let's go into these options. So the main thing that we can offer that has the most impact on future success for women who are older is fertility preservation. And of those techniques, the main thing that we utilize is usually egg freezing and sometimes embryo freezing. So this is an option that is particularly talked about for women who undergo egg-destroying treatments before they start the treatment, such as chemotherapy or radiation for cancer or other conditions. But also increasingly, this technology is being utilized for women who wish to delay childbearing till later in life. And we call that now planned oocyte cryopreservation. This is not a perfect solution by any means. It's expensive. Doing the treatment requires time and money, and the medications are expensive to do the ovarian stimulation. It requires a minimally invasive procedure with anesthesia. When we look at the outcomes on children born from frozen eggs, we see that the outcomes overall appear very similar with garden variety IVF that uses fresh eggs. The statistics, the epidemiology on this shows that we are doing this more and more in the United States. And so if in this chart that looks the trends from 2013 to 2022, we see that the overall assisted reproductive technology cycles are clearly increasing in the United States. But if we specifically look at the banking cycles, we see that they started out at a low number in 2013, but has had the biggest rise and is attributed to most of the ART rise in this country. So we are doing more and more egg freezing, more and more embryo freezing for the future. It is important to emphasize that freezing eggs does not guarantee success with those frozen eggs when a woman's ready to use them. It is simply a way to try to improve the odds of success later in life. We still don't have great volumes of data to accurately predict success rates, but we have pretty good models based on the data that are available. And these models show us that the chance of success is dependent on two main factors. Number one, the age at which the eggs are frozen, and number two, the number of eggs that are frozen. So here is a chart from one of these mathematical models that was published in 2017 that we still utilize today. And it shows us by age group the chances of a live birth. So for women who are very young, we see that if they're able to freeze 10 eggs, they're going to have roughly an 80% chance of a live birth when they go to use those eggs. On the other hand, women who are older, so for example, at the age of 40, we see that 10 eggs would only result in a less than 30% chance of a live birth. A rule of thumb that often is quoted, that if we look at women at the age of 38 and we look at 20 eggs, we see that we get about a 70% chance of a live birth when those eggs are used. So overall, women under the age of 38 who are able to freeze 20 more eggs will have a 70% chance or better of a live birth. So that's an easy statistic to remember to use for counseling. We also see that the use of frozen eggs remains quite low at this point. So if we look at the collated data in this one review, we see that only about 12% of women they looked at who froze eggs only ended up still using them at this point. We see that the egg survival rates overall nationally are reported around 80%. So about 80% of eggs survive when they're thawed. And we see that the fertilization rate is around 2/3, which is about the same as for fresh eggs. And then the live birth rate, around 35%. Again, for all comers, that's roughly the same as fresh eggs. And then the question that we often are faced with is, what is the ideal age for egg freezing? And we don't have really an answer for that. It depends on priorities and values and goals. So you can argue that freezing eggs at 25 may be the best idea because we'll get the most eggs, the best quality eggs, and the best chance of success when we go to use those eggs. On the other hand, we know that even as it is, the usage rate is quite low at only 12%. If many women start freezing their eggs at their 20s, they may never use those eggs, may never need those eggs at all. So these may be very unnecessary procedures to put women through, which are not without risk and concerns, as well as the cost to the individuals or society for women who have insurance that actually covers this. On the other hand, if we wait too late, then there's not going to be enough good eggs to use. And some women have diminished ovarian reserve and are not able to get eggs even in their 30s. So there's not an ideal age for everyone that we can offer, but generally we counsel that it's best before the age of 35 and up to 38. We still have a good chance for most women to yield a good number of eggs, to yield a good chance of success. If a woman is ready for pregnancy and has not frozen eggs, has not done any fertility preservation in her later reproductive years, we can try to improve the chances of pregnancy occurring. And so we have our traditional fertility treatments, such as ovarian stimulation or superovulation with medications like Clomid or Letrozole or FSH. The whole concept here is that these medications try to get more than one egg to grow. 2 or 3 usually is the goal, increasing the odds that one of those eggs will be normal, fertilize successfully, make it into the uterus, and implant. So it's simply a numbers, an odds game. The more eggs that are released, the higher the chance one of them will be successful. But of course, this strategy comes with a price, multiple gestation. So the more eggs are released, the higher the chance of having more than one baby, which of course comes with its own set of complications and risks. So in general, the strategy is to try to aim for 2 to 3, but not more than that because of the increased risk of multiple gestation. And this strategy only helps a little bit because still the majority of the eggs being produced are going to be abnormal and will not be successful. To supplement that, intrauterine insemination IUI can be done to get the highest number of motile sperm into the uterus at the ideal time to maximize success rate combined with superovulation. And then in vitro fertilization, IVF, that allows us to collect as many eggs as possible within one cycle to maximize the yield, which then increases the odds of finding the normal eggs, which yield to normal embryos. It is not clear whether we can significantly impact egg quality, although a number of studies have shown that there are some things that we can do. Lifestyle has been shown to be important. It's recommended that harmful factors, smoking, drug use, alcohol, should be eliminated. And positive, healthy living is strongly encouraged, which includes a high-protein diet, utilizing more fresh foods and less ultra-processed foods, weight management for women who are obese or overweight. Stress management also has been shown to be important for those who are in high-stress environments, and that's, of course, hard to help, but stress coping strategies are recommended. Counseling, acupuncture may have some role in that as well. None of the supplements that are advertised on the market to women have been conclusively shown to be effective. Of all of these, the one that has the best positive evidence behind it is the CoQ10. But even here, the data is quite limited and mostly animal data that shows benefits. The main feature to help battle aneuploidy within the IVF collected embryos is PGT-A, Preimplantation genetic testing for aneuploidy. So here, of course, we do IVF to create embryos. And then as those embryos reach the blastocyst stage of development, biopsies can be done with cells taken from the trophectoderm, usually 5 or 6 cells or so. And then the embryos are cryopreserved. These cells then can be analyzed using either next generation sequencing, SNP arrays, or a combination of both to assess the chromosomal makeup of these embryos. then we can identify which embryos are normal and which are abnormal. The abnormal embryos would not be used. And then if we do achieve a normal embryo, that would then allow us a much higher pregnancy rate with a much lower miscarriage rate and lower risk of trisomy and aneuploidy in the child. So this technique is very powerful in finding and achieving the highest chance of success with a single embryo transfer. It is not perfect here as well, and the debate continues about the usefulness of using PGT-A and for whom it is most helpful and should be offered. On the con side, we know that it cannot improve the cumulative success rate. So if, for example, we do an IVF cycle and we achieve 4 blastocysts, if one of those is normal, we do the PGT-A, we find that normal one, discard the 3 abnormal one, and put the normal one in the uterus to give us the highest chance of success. But we can't improve the cumulative success of that IVF cycle because we can't fix the abnormal embryos. We simply identify which ones we should use. So if we didn't do PGT-A, we would transfer 1 or 2 embryos at a time and eventually hit on the normal one to give us still that possibility of success. But it may take multiple transfers with potentially poor outcomes, miscarriages, etc., before we get to that normal embryo, unless we get very lucky. Secondly, there's always a concern that the testing is not perfect. Are we sometimes calling an embryo abnormal, whereas that embryo may still have had potential to succeed? And this was particularly an issue in the previous years, where mosaic embryos were routinely discarded, whereas now we've identified that most low-level mosaic embryos have almost the same or the same success rate as embryos that test completely normal. So that's less of an issue now, but remains a concern for some critics. And then lastly, while we've done thousands and thousands of cycles using PGT-A and have thousands of babies born, we still don't have really long-term data to be absolutely sure that there is no risk to children born through embryo biopsy transfers. And at this point, we have no data to suggest that at all, but that remains a possibility that we cannot completely rule out. On the positive side, of course, we have that there's a much higher implantation rate when we use chromosomally normal embryos. So one of these embryos being transferred to the uterus should have at least a 60% chance of success or better. We are routinely transferring only a single embryo because we have a high success rate. So we are greatly reducing the multiple gestation rate, which was such a problem in the previous years for use of IVF. We are achieving a much lower miscarriage rates with PGT-A. We know that rate is below 10%, whereas, as I showed you earlier, women who are older have a very high miscarriage rate. And then even though upfront we have a higher cost for doing the PGT-A, the overall savings in cost analysis that have been done show that overall it is a significant cost savings for most and a time savings as well. For those who are ultimately unsuccessful with their own eggs and have no frozen eggs or embryos to use, then we can offer the option of using donor egg or donor embryo. So here the concept is fairly straightforward, where we can take eggs from a 20-something old woman, combine them if there's a heterosexual couple, for example, with the patient's partner's sperm to create embryos, or combine them with donor sperm. And then the resulting embryos can be transferred to the patient's uterus. So she still carries the pregnancy, experiencing the positives and negatives of pregnancy, as well as of childbirth. It's her child. It is her partner's genetic child because his sperm was used if she has a male partner, of course. And for her, it's not genetic child because it wasn't her egg. Its success is very high because it's mostly the quality of the eggs that predicts the chances of success. And if a woman is in good health, she can be offered this treatment into her 50s with continuing high success rates, as you can see in this diagram. So that's what we have in our toolbox at this point. What can we look to in the future? Well, the main strategy that is talked about and frequently hits the mainstream media is mitochondrial replacement. It goes by many names: mitochondrial transfer, three-person reproduction, three-person IVF. There's more than one technique for how this is accomplished, but in general, this is a construct of using embryos that are created with genetic material from three individuals. So we can take our female patient's nuclear DNA, combine it with the donor egg mitochondria, and then inseminate that egg with sperm from the patient's partner. This can be done, as I said, in several different ways. One common way that's being used is that you take the patient's eggs, you take the nucleus from those eggs, you take a donor egg from a young woman, you remove the nucleus from that donor egg, you put the patient's nucleus into the donor egg, and then inseminate that egg with the patient's partner's sperm or donor sperm, etc. So because mitochondria have DNA, this is how you end up with DNA from three individuals in one child, potentially. Because of this is heavily regulated and not used in the United States clinically at all, although research is being done. It is mostly indicated for those women who have severe mitochondrial disorders who do not want to pass on these disorders to their offspring. The biggest study in the recent years was just this year, published in Britain, where they have a series of babies that have been born using a similar technique in mitochondrial disordered individuals. But you can see how this technique can also be applied to older women whose eggs have potentially aneuploidy, and the nucleus could conceivably be taken not from the aneuploid egg, but from a skin cell or another cell in the body. Or if the nucleus is not the only issue, the mitochondrial dysfunction that we see with age, if we can do a mitochondrial transfer from a young egg, that can address that problem. So there is potential for these techniques, but there are significant ethical concerns, and it is not clear what the future holds on this front. None of the other treatments that have been studied have been shown to be beneficial. The one that's still being researched right now is injection of platelet-rich plasma into the ovaries in women with diminished ovarian reserve, although the evidence at this point does not appear to be very promising. So in conclusion, in the United States, fertility rates continue to decline. Women are delaying childbirth till later in life, and that's creating more and more problems with reproduction. The advanced maternal age is associated with increasing incidence of infertility, pregnancy loss, pregnancy complications, and then aneuploidy in live-born children. Women are advised to complete the childbearing before the age of 35, if at all feasible. For those who cannot accomplish that or choose not to accomplish that, fertility preservation options are available, particularly egg or embryo freezing, and the use of these techniques continues to increase. By no means should this be seen as a guarantee of future success, but rather a means of increasing the odds in the future. And we do have some tools that allow us to help improve pregnancy rates in women in later reproductive years, but these are far from perfect and limited by the low ovarian reserve that often is encountered with age. And then lastly, for those who are not successful with their own eggs, then donor egg or embryo options are a successful alternative that is utilized frequently. With that, I'm happy to take any questions.
Thank you, Dr. Kovalevsky. We're now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Dr. Kovalevsky, our first question is, for those patients over the age of 35, how many rounds of Clomid or Letrozole would you recommend trying before referring a patient over for IVF?
Time becomes increasingly precious. Studies have been done to show that the most successful strategy is not to delay and go straight to IVF when possible. So in general, we recommend limiting to 3 or at most 4 of those less aggressive options prior to proceeding with IVF, because beyond that, success rates drop with that approach faster and faster, and time becomes more and more precious.
Thank you. The next question is, you mentioned the DNA fragmentation in sperm increases with age. At what point do you consider having a DNA fragmentation test completed?
So that's a great question. Our data is still being collected. So we still don't know for whom we should be offering the DNA fragmentation test. And should it be a routine screening test for anyone with infertility, or should it be reserved just for those with recurrent pregnancy loss? So we don't yet know the proper indications for doing the testing. In general, for me at this point, I use it mostly for couples who have recurrent pregnancy loss. So that's probably the number one most common indication. Or if we see poor embryo development in the laboratory for reasons that we cannot otherwise explain. So it's not a routine test for everyone at this point, but anytime we have suspicions that embryo quality is poor for reasons that we can't identify, it's a good test to consider.
Thank you. Our next question is, do you see any downsides with women and egg quality when taking stimulants and/or antidepressants while going through IVF?
So an interesting question. Overall, the simple answer is that no, we don't see any significant problems with egg quality in women using antidepressants. And this is something that we see a lot because a large number of the population today is using antidepressants, and it does not appear to be a significant factor in egg quality.
Is it preferred to freeze eggs or embryos?
So, great question. It all depends on why you're doing this. So if a woman is coming for fertility preservation and she is single and has no idea if she's going to have a partner in the future or who that partner is going to be, or if she is in a relationship and is unsure that she's going to have children with this current partner, or just wants to be sure that she has the freedom to choose in the future, then clearly egg freezing is what needs to be done, because that's the way that you would have the freedom to combine these eggs later with sperm from any source that she chooses. On the other hand, embryo freezing commits her to using the embryos that have already been created with a specific partner sperm or donor sperm. So it's quite limiting. Why would someone choose to do embryo freezing? Well, because embryo freezing is more successful somewhat, and we're able to prognosticate better with embryos than we are with eggs. So currently, if we freeze a blastocyst in our laboratory, we have a 98% survival rate of that blastocyst, and we have pretty solid data that we can quote what the chance of success will be with that one blastocyst. Whereas that data, as I showed you, is not nearly as strong for the eggs, and the survival rate is lower, somewhere 80 to 90% with the eggs. So embryo freezing may be a little bit more robust and has a better chance of success in the future, but has significant limitations for a woman's ability to choose whose sperm she would want to use.
All right, our next question is, what age was the oldest woman you assisted to get pregnant using these artificial techniques? I guess you can also answer a question like, what is the age cutoff for IVF or maybe donor egg as well?
Yeah, so in general, IVF is highly unsuccessful after the age of 44. So the oldest woman that I've helped go through IVF was at the age of 45. And those are very uncommon cases. Those are women who have still very good ovarian reserve, so the quantity of eggs is still high despite the age being 45. And we know that the quality of the eggs is very poor. So we need a high ovarian reserve to have any real chance at all of finding a normal egg and making a normal embryo. On the other hand, for use of donor egg, donor embryo, we can go later on in life. And so the oldest that I've had a pleasure of helping was at the age of 53. And here again, we have to be very careful to choose that it makes sense to do this on a number of levels. So first, of course, health-wise, pregnancy is a huge stress on the cardiovascular system. So a thorough cardiovascular evaluation needs to be done along with routine testing to make sure that it's safe to pursue pregnancy. Consultation, maternal fetal medicine, to discuss all the risk factors for somebody attempting pregnancy at that age. And then, of course, there's ethical considerations. And a lot of debate exists whether we should have a lower age cutoff, because we have to consider the child that will be born. And should we be using just a woman's age as a cutoff for having a child? Should we be using the couple's combined age or mean age because of the issues for the child? Will the parents be there to provide the appropriate support and caring for that child as he or she grows? So this is quite a complicated issue with no simple answers. But the way the question was specifically phrased for me personally, that was 53.
Thank you. And then this is our last question. What are your thoughts on low-dose rapamycin for older women for egg quality? Is there enough data to support its use?
Yeah, so that is one of the areas that has been researched in the recent years, and there is some promise in it still. But no, I don't think our data is nearly enough at this point to make any recommendations whatsoever. We don't know enough about benefits, risks, costs. So no, at this point, we're not using it at all in our practice.
Thank you, Dr. Kovalevsky, and thank you everyone for attending today's webinar, Age and Fertility. If you have any additional questions, you can contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you could complete the survey to provide your feedback to help us with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF, Delaware Institute for Reproductive Medicine, the EV-RMA North America Network, and Dr. Kovalevsky, thank you for joining us and enjoy the rest of your day. Thank you, Dr. Kovalevsky.
Thank you. Bye-bye.